It's still saying. Just give me 1 second, Angie.
Recording has started.
It says recording started.
Yep.
Okay, and you can hear me?
Yep.
Okay, then I'll just go ahead and record it now.
Okay, wait, now see if you can pull up your,
Well, let me share the slides and let me know, okay?
yeah, that's what I said.
Thanks, Angie. Okay, now can you see the slide?
I can see the slide.
But can you see me?
Yep.
Okay, I don't see myself, but it's okay. I can go over them like half an hour, okay?
Hey,
Okay.
let me take a picture of my screen and then we can start your screen.
What did you say, Angie?
I took a picture of the screen, of my
Thanks.
screen. I'll show you. I'll come in there and show you.
Thanks, yeah. Okay.
Actually, better if you leave it like that. See how that looks? Whoops.
Okay, yeah, I'll just leave it, then I'll just.
Yeah, so doing it the other way, you know what I mean?
Yeah, I'll just start recording now.
Okay,
Yeah.
so I'm gonna,
You're leaving.
yeah, I'm gonna leave
Okay.
it so you can.
Thanks, this is Angela.
You can hear the feedback. Can you hear it?
Yeah. Okay. Nice to see all of you. Okay, Dr. Nasrat, 2006 graduate. So I did my residency and fellowship here in the United States, and currently I work as neurologist in Blessing, Quincy, Illinois. Okay, so we'll go over. Hey Angie, can you still see the screen? Can you show and see if you're seeing the slides, because I feel the slides is left. Can you see the slides, or should I share?
No, you have to share. I don't see
Oh,
that slide.
okay. Let me share the slide then. Okay, can you see them now?
Yes.
Okay, can you just silent and leave it, because when you logged off, the shares disappeared. Yeah.
I would have saved it, yes.
Thanks. Yeah. Yeah. Sorry for this. I'm new to this software team, so I don't know that much about team. I had to call Angela. Okay. So Angela, you put on silent. I still can hear myself. Thanks. Okay, so Dr. Nasrat, again, 2006 graduate from Drebes University. Then I did my residency and fellowship at Wayne State University, Detroit, Michigan. Currently I work in Blessing, Quincy, Illinois. So we'll go over meningitis today, and it should be quick points. Most of you know these points, and we'll go over 3 cases I've seen here in Blessing Hospital. Okay, so we'll start with bacterial meningitis, and the causes like a neonate or up to three months. Group beta streptococci is one of the most common cause. You know, this bacteria lives in birth canal of the females, and baby can contract infection during delivery. E. coli also, like from the colon. So these two, with strep pneumonia, is the most common causes in unit. Like 3 months up to adults and elderly, strep pneumonia is the most common cause. And you know, you should consider listeria neonate or patient older than 50 years, also immunocompromised. Okay. Also, you should consider skin bacteria like staph, strepto, after brain surgery or trauma to the head. We'll go quickly over the causes of aseptic meningitis. So aseptic meningitis means aseptic meningitis means meningitis with negative cultures. Okay, so viral is the most common cause, like enterovirus is the most common causes. RNA viruses like Coxsackie, Echo, and rhinovirus. Because we're from Libya, so always consider rabies, okay? Rabies can start just with altered mental status or like brain infections, then, it travel from the skin to the cortex, to the nerve axon. It can cause weakness, can cause like dysphagia, hydrophobia, aerophobia. Okay, so I put this because Zawiya is my hometown, and I still remember, like, even in 2006. So I left Libya 2008, but in 2006 until 2008, if you're from the Zawiya, clearly you can see the bats flying after sunset. And I did not see like crazy dogs, but I just put it here to put in your mind that please always consider rabies, okay, in your differential diagnosis. I did not see rabies here in the States yet, but we also like, it is still possibility even in the United States, okay? So this is another like viewpoint about rabies, like diagnosis, skin biopsy, post-exposure prophylaxis. Arboviruses, like this viruses comes from mosquito or ticks, like West Nile viruses. I've seen few cases with West Nile viruses here in the state. Esrin, equine encephalitis, dengue, Zika also. So I put like the MRI image, what you see in this arboviruses, because it's very interesting and it has a broad differential diagnosis. So if you see MRI with hyperintensity in basal ganglia or, either basal ganglia or thalami or brainstem on both sides, so you should consider arboviruses. There's many other diseases can cause this hyperintensity, even Wernicke's can give you similar hyperintensity. I know common site is mammalian body, but it can happen the same intensity. And they also come with confusion in Wernicke's. Also liver disease with hepatic encephalopathy. It's Wilson disease. So it's a broad differential diagnosis, but if you're thinking about infection, please consider arboviruses with this MRI finding, okay? So measles, mumps, rubella can do that also. There's something called recurrent or malarial meningitis, and I have case like this. Okay, so like I have 60 years old white lady. She gets meningitis every like 1 year or 2 years. She said whenever she's stressed out, she get fever and headache. I tap her, I found HSV number 2. So this is one of the most common cause of recurrent meningitis. Like chemical leaks from cyst also can cause recurrent meningitis or craniopharyngioma. Lyme disease, syphilis, HIV, connective tissue disease can also cause recurrent meningitis when the patient has flare-up. Cryptococcal meningitis. So I put one slide on cryptococcal meningitis, and also I thought I can put, I've seen a lot of cases with cryptococcal meningitis. It's fungal, it's common with HIV, immunocompromised. So the unique things, or the most important thing in cryptococcal meningitis, like they get very high pressure. So I remember even young, he was 20 and his pressure was so high. We did lumbar drainage, then we had to shunt him. So if you miss high pressure in cryptococcal meningitis, your patient may herniate. And also, like how to measure intracranial pressure, you just, when you tap the patient, you have like, if you want to do the baby position on one side, so you have to extend his leg and see the tube how high it goes. So normal pressure should be less than 20, but you will see very high pressure with the cryptococcal meningitis. Histoplasmosis. Now I have patient in a hospital with histoplasmosis. So it's very typical, like starting her lung and now she has fish in her pulsing. So I just tapped her yesterday and it's in the lab, like histoplasma antigen, cultures 30% sensitivity, but I'm still waiting for results if the histoplasmosis went to her brain or not. Plastomycosis, it's also fungal that starts in the lung, skin, and also it can go to the brain. And this is also part of aseptic meningitis, because if we do bacterial cultures, it came back negative. So clinical feature of meningitis. Now, patient can be asymptomatic, just mild headaches, and he has meningitis or encephalitis. I remember in New York, I was a senior, like 4th-year resident, and African American. He came to ER with just mild headaches, and he feels discomfort in the back of his head. So the ER resident, they always want to do lumbar puncture. They want to learn. So she convinced him, like, I want to do lumbar puncture because you have a new headache, your CT scan negative. So she did lumbar puncture. He went home. He did not even want to stay and wait for results. After the following day, HSV came back positive. So meningitis, even slush encephalitis can be very tricky. So the common features like fever, headaches, neck stiffness, meningeal irritation signs has low sensitivity in adults. So diagnosis, anyone who comes to ER with fever, headaches, we do CT scan, it's a quick, okay? And you rule out like tumors, bleed, and then if the patient you think has meningitis, you do lumbar puncture. Now, even before you do lumbar puncture, even if you can before CT scan, if you suspect meningitis, start the antibiotics. The first step, you start antibiotics, okay? And antiviral, and we will talk what regimen we do, okay? Now, lumbar puncture, cells, protein, opening pressure. If you want to do opening pressure, I highly recommend anyone with HIV, even before you get the results of cryptococcal meningitis, you do the opening pressure, okay? Cultures, HSV, PCR, so we send all these labs, So bacteria may take like 1 to 3 days, intercellular may take up to 5 days. We use PCR in Listeria and HSV. So lumbar puncture with high RBC or traumatic lumbar puncture. This is very common in the practice. You do lumbar puncture, the blood leaks into CSF, and so that's confusing. Like blood has a protein, it will give you high proteins. Blood has white cells, so it give you high white cells. Now, how you correct it? So we correct it based upon the ratio between WBC and RBC in the blood. So you have patient. So like, for example, like the common like subtraction people use, like take 1 WBC from H500 RBC in your CSF or the patient CSF. So for example, if you do lumbar puncture and the RBC 1000 and the white count in the CSF is 8 or 10, let's say 10, okay? So RBC 1000, white count is 10. So based on the ratio, take 1 white count from CSF for H500. It's like the ratio of the blood, okay? So you take 2, so the corrected white count in the CSF is 8, still high. Now, where did this come from? So let's say like this is, take the white count is 5,000 in the blood, and the RBC is like 2.5 million. So if you divide 5,000 to 2.5 million, so that's, or 5 million, that will be 1 to 500, okay? Now, let me give you something easier to understand this. Like if you do CBC and the white count is 1,000, okay? And the RBC, let me correct this. Yeah, I think. So, and the RBC and the CBC is 200,000. So if the ratio here of WBC to RBC is 1 to 200. So here, patient is anemic. So you take 200 RBC. So 200, like you take just one white count for each 200 RBC in your CSF. Like let's say for this patient, if you do lumbar puncture, his white count in CSF is 10. His RBC count in CSF is 600. So you take 3 white counts from the CSF, it will be 7, okay? So if I confused you about this, you can take my cell phone from Dr. Nader Shaka. By the way, thank you very much for everyone inviting me to be part of your educations, okay? You can take my cell phone from Nader Shaka and you can vote me, or sorry, you can like Viber me or WhatsApp me, or you can even call me. And please consider like 7 hours difference between Libya and the United States. So herbovirus, we send IgM, IgG, PCRs, and this is lymphocytic choriomeningitis. Yeah, I want to talk about this, but sorry, I did not get enough time. So treatment of meningitis, okay? So anyone who you think he has meningitis or she has meningitis, you don't need to wait for lumbar puncture, you don't need to wait for CT scan or MRI or anything. Go ahead and start the medications, okay? Even if the diagnosis is wrong, it doesn't hurt the patient to start antibiotic. You can take them off, okay? But if the antibiotic delayed, that can hurt your patient. So we start with ceftriaxone, so it would cover like the E. coli or gram-negative bacteria from the colon. Vancomycin would cover the skin bacteria like staph, strep pneumonia is the most common cause. Also, it can live in your nasal pathway or ears or something. And ampicillin to cover the listeria, and acyclovir to cover the HSV. Okay. So if you're suspected, please go ahead and start. Don't wait. Okay. So this is a slide about use of dexamethasone and meningitis. So in general, if you're highly suspicious for bacterial meningitis, like high fever, high white count, confusion, you can start with 10 milligram IV Q6 hours from 1 to 4 days. So the study showed that it's mainly prevented or like systemic complication like septicemia, but it does not prevent the CNS complications. Okay. So, and also said if your patient has HIV or cryptococcal meningitis, it can increase the mortality. Yeah. So don't start dexamethasone in patient with cryptococcal meningitis or HIV. So this is the common complication of meningitis, like seizures. By the way, seizures can be very tricky. Like the common seizures we know is convulsions, like either generalized tonic-clonic convulsions, twitching, staring off, gaze deviation to one side. So this is like you can see abnormal movement, okay? In addition to confusion or unresponsiveness. But seizures can be just electrographic. You see the patient confused, like he doesn't follow simple command or complex commands. And you see only seizures in EEG. So please consider EEG in patient with brain infection and confusion. Then don't assume this is encephalitis and that's it, okay? So empyema or collection of the pus in the meninges, brain abscess, hydrocephalus, stroke, sinus thrombosis. So this is like common complications or one of the most common complications of meningitis. So this is case number 1. So I put 3 cases from my practice. Honestly, I have more very interesting cases, but sorry, like I'm getting busy with coronavirus and everything. Inshallah, if I get time, we'll do more slides in future, inshallah. So case number 1, this is 42 years old Caucasian lady with antiphospholipid syndrome. She was incomatant or blood thinner. She had gallbladder cancer. She had surgery and per her oncologist, she is cancer-free, no recurrence. Okay, so she was admitted to blessing with the headaches and syncopal episodes. So she said she was doing something in her home, then all of a sudden she fainted and hit her head. Okay, so when I saw her, her exam was completely normal. She continued to have headaches. So I did MRI. I found brachiomeningeal enhancement. So we will talk. What does it mean, brachiomeningeal enhancement? What does it mean, leptomeningeal enhancement? So I missed that. Sorry, I think I will go back to this. I think I missed one slide and I jumped. Okay. Now, anyhow, we did MRI, which showed the brachiomeningeal enhancement. So, patient with brachiomeningeal enhancement, you have to number 1, you have to rule out cancer. Okay, carcinomatosis, and then rule out reduced pressure. Like she hit her head, so if she had CSF leaks, she can get brachiomeningeal enhancement. But so I did CT chest, make sure we're not missing other cancers or sarcoidosis, came back negative. I did lumbar puncture, initial results came back normal. Cytology cytology came back negative. So you have to be very careful with cytology and CSF. So the sensitivity is very low, like 30%. So if you're still highly suspicious of cancer, you have to repeat it 3 times to reach sensitivity 90%. So the recommendation to repeat 3 times. Yeah. So I'll be there like in 10-15 minutes, okay? So we have to repeat 3 times to make sure we're not missing cancers, okay? So I send like connective tissue disease panel, so ANA including like lupus antibodies, Sjogren syndrome, and other connective tissue disease antibodies, all of them came back negative, A and CA also. So, so CSS culture is negative, oligoclonal band came back positive. So what's oligoclonal band? We use this term even diagnosis now of multiple sclerosis. So in the past, it was not like part of the criteria of MS, even though we do it, but it was not part of the criteria. But now oligoclonal band is part of the criteria of multiple sclerosis. It can cover like 2 times, okay? That's different story. So maybe in the future, if needed, we can talk about MS, which you don't need it in your ID, but if you want to know about it, you know about it, we can talk about it. So this patient has 3 oligoclonal bands. So that's mean 3 bands of IgG, okay? So because that's point to the inflammation. So I did a steroid and she improved. I repeated her MRI 6 months later, her Beckman enhancement improved. Now, what do you think? What causes her Beckman enhancement? Is it trauma with reduced pressure like CSF leaks? It is possible, but we found oligoclonal band. So oligoclonal band point to inflammations. Now, if you see any articles like trauma or reduced pressure can give you oligoclonal band inflammatory process, let me know. I'm not aware about that, but feel free to email me, okay? For any questions, any concern, if I said something not clear for you. Inflammation is possible, okay? Now, this is the likely diagnosis. So let's go back, like, what does it mean leptomeningeal enhancement and what does it mean Beckman-Langerhans enhancement? So leptomeningeal enhancement or leptomeningitis, it's inflammation of the perimeter and arachnoid, okay? And Beckman-Langerhans enhancement is from outside, it's the inflammation of dura mater. So when you give the contrast, if the meninges take the contrast, that's mean inflamed. So leptomeningeal enhancement, make sure this is not infection, that's the most common. Beckman-Langerhans enhancement, you need to make sure this is not a cancer, okay? Now the other causes, they are almost the same, except with reduced pressure, you see mainly Beckman-Langerhans enhancement. Positive vasculitis, sarcoidosis, connective tissue disease, bacteria, viruses. So let's go to case number 2. So these 3 cases from my practice, okay? 73 years old, Caucasian man with esophageal cell carcinoma, stage 4 with mets to the lung, abdomen, and looks like he had radiation led to urethral structures. Just 1 week before the admission, he had the urethral dilatation surgery, okay? So he was admitted to the hospital with fever, and a neurologist was consulted for mild headaches. So he said, I just have mild headaches in the back of my head, and he said he usually gets headaches, okay? Now, that's confusing, mild fever, headaches, and he just had urethral surgery. So his exam is normal. So I told him, like, because if your UA is negative, and this is what I use in my practice, like fever headaches or fever confusion, okay? I start with UA, chest X-ray, blood cultures. Now, first of all, I start the antibiotics because I suspect meningitis or encephalitis, so I go ahead and start the 4 medications. Then if UA came back negative, chest X-ray came back negative, blood cultures. Okay, I don't usually wait for blood cultures. Then I just go ahead and tap him, do lumbar punctures, okay? And I clearly told the patient, like, you have fever, you have mild headaches. Even you said this looks like your usual headaches. But I don't find reason why you're having fever. So and his UA is negative. So that's why I had to do lumbar puncture. So I started the medications before the lumbar puncture. He had MRI showed small vessel disease or like very white spots here and there. Lumbar puncture showed nuclear cells is 256. Okay, so this is the right, like this is from my practice. But if you want me to change it just for training purposes, like if I do this is 1000, then I will add here corrected. And nucleated cells or white count 46. Sorry, 254. Yeah, because I took 2 white count from the RBC because of 1000 RBC in the CSF. So culture is negative, HSV is negative. So he was discharged at home in oral antibiotic, okay? And then just 2 days he came back confused. So he was confused, he was not following command. So what's your differential diagnosis in your mind if the nurse called you, your patient came back and he became confused? Again, electrographic seizures is very important differential diagnosis. I did EEG, came back negative, emphysema, I repeated his MRI, no bus collections, strokes, I repeated his MRI, no strokes, no sinus thrombosis, and this is his MRI, okay? So he had hydrocephalus because it looks like he had too much inflammatory process, and that's maybe affected the range of CSF and given back pressure. So you see this white changes here. This could be small vessel disease, but in acute hydrocephalus, also the CSF leakage in the brain will give you white spots like this, okay? So we'll go to the last case. So case 3, 66 years, again, this is all of them my own patient. 66 years old, Caucasian lady with history of pancreatic cancer. So she was admitted to blessing, change in mental status and responsiveness, okay? So she got intubated, she spiked fever, okay? Now, again, fever confusion, consider meningitis and encephalitis. Again, don't assume this is confused because of encephalitis. You have to consider complications, okay? So what's the best next step? Like fever confusion, go ahead and start the antibiotics, okay? Now in this age, even if she had bad bladder infections or pneumonia or like septicemia, it will make her confused, even if she doesn't have meningitis. But you don't need to wait until you do your HS X-ray blood culture. Just go ahead and start acyclovir, ceftriaxone, ampicillin, and vancomycin, okay? So I did lumbar puncture, and believe me, as soon as I did the tap, when I saw the blood, I told my nurse, this is HSV, because the blood looks bloody. And you know, if it's traumatic, you see too much blood in tube number 1 and the blood become less and less. But if it's HSV, the first one, you may not see blood or changes or xanthochromia, then you can see the more blood within tube. It's not very typical, but in this patient was very typical, okay? It's not always typical, but in this one was very clear. So he had 31 white count in his CSF and RBC 500 something. So you have the corrected here. Let me add corrected. White count 30. Oligoclonal bad came back 0, VDRL came back negative. Now, why the patient confused? Okay, so I did stats EEG. She had status epilepticus, okay, from her infection. I did MRI, and sorry, I did not put the EEG. This is her MRI. So this is the midbrain looks Mickey Mouse. Okay, this is her temporal lobes. This is her temporal lobes. So you see the hyperintensity in temporal lobes. So this is very common side of HSV infections. But also it can happen with autoimmune encephalitis, okay? So what's differential diagnosis? Herpes, autoimmune, that's the most common. Now, radiologists think also could be strokes, but I don't think so. It's not the vascular distribution, okay? And so that's the problem, like herpes PCR. So I really was treating HSV encephalitis, but the HSV came back negative 1 and 2. Like sensitivity is 97%, so it's very sensitive, okay? Now, paraneoplastic and autoimmune panel, it came back negative. So it's not autoimmune, it's not HSV. So what's the best next step? I'm still very highly suspicious of HSV, okay? So I send the IgG, CSF IgG. So IgG HSV1 came back negative. HSV2 came back very high. So I just found a study like if this study, like if the IgG is too high in CSF, that can like give you false negative PCRs, okay? Now, I am very sorry I was quick. I really have patient waiting for me. And inshallah, I feel very happy to participate in your educations, okay? Inshallah, in future, if needed, we can do more slides, okay? And more infections. And I have patient now in my ward with histoplasmosis. She's young, 30 something, and she had histoplasmosis. So that was also a good case to present, but sorry, I could not find time to add it. السلام عليكم إن شاء الله إن شاء الله نشوفكم أخصائيين إن شاء الله يا رب وربي يوفقكم إن شاء الله وبكل صراحة إحنا حصلنا فرصة تدريب في أمريكا لكن أنتم خير منا إن شاء الله أنتم تخدموا في ليبيا وأنتم تدربوا في ليبيا وأنا متأكد كل حد حصل الفرصة هذه حيدير خير مننا إن شاء الله، ربي يوفقكم إن شاء الله يا رب. موفقين، وأنا سعيد جدًا إن في طرابلس بدنا نديروا فيه دبلومة. شكرًا دكتور نادر، وشكرًا لكل حد شارك في هذا البرنامج. كويس، وإن شاء الله نشوفوا دراسات من طرابلس يا رب. السلام عليكم.